Evening to one and all. Thank you to Aliwal sir for the opportunity. So today let's talk about something called capsular bag distension syndrome with sulcus IOL acting as a seal. I have no financial interest to disclose. So this was a 68-year-old female who underwent an uneventful manual small incision cataract surgery which presented with insidious onset, gradually progressive, painless diminution of vision after 1 week. She presented at the end of 1 week with finger counting 1 meter and the other eye was 6/6 pseudophakic. So when the patient was discharged, the patient was having 6/6 vision, but after 1 week, she developed finger counting. Slit lamp examination revealed a quite anterior chamber without any cells, without any reaction, with the IOL in the sulcus, relatively smaller capsular rexus of about 5 millimeters, and the IOL optic was covering the rexus margin in a symmetric fashion. Preoperatively, this case was an intumescent mature cataract. There was an opaque colored, turbid, white fluid that has accumulated behind the IOL, and the rest of the fundus details were hazily seen due to the fluid turbidity. The right eye was pseudophakic with normal fundus study. We did a B scan and it was anechoic, no vitreous cells or point echos, so end-off was ruled out. And then we did an anterion, which suggested us that it's a case of capsular bag distension syndrome to the tune of approximately 347 microns. So you can see at the first image, that's the anterion image. Normally, in an uneventful manual small incision surgery, the capsular bag distension occurs when the IOL is in the bag normally. So this was a case when the IOL was in the sulcus, still we found there is a distension of 347 micron. So we did a two-phased treatment. First phase is we tried to bombard the posterior capsule by doing a posterior shift of the ND-YAG capsulotomy. So we tried to bombard the PC. Having said that, it failed, and then we had to take the patient again in the OR complex next day for the clean wash, for the AC wash. And then the next day, the vision was improved to 5/60, and at the end of the one week, again to 6/9, and then at the end of 1 month, it was 20/20. So this was being published as a capsular bag distension syndrome with sulcus IOL acting as a seal recently in IGO. So till today, we know all about 3 types of CBS, which has been described as per the literature. First was intraoperative CBS during hydrodissection, where sudden increase in the pressure inside the capsular bag leads to the posterior capsular rupture and the lens drops in the vitreous cavity. That was the age-old study. Secondly, early post-operative CBS occurs due to retention of viscoelastic or a particulate matter between the optic of the IOL and the posterior capsule after an uncomplicated cataract surgery. The third was a late onset. It could be months or years after an uncomplicated cataract surgery with in-the-bag IOL placement. So why is this case so unique? So the take-home message with this case scenario of an intumescent mature cataract was that CBDS may happen at any point of time with a small rexus and with specially an intumescent mature cataract. So what are the points to remember for the beginners doing SICS? Immense cortex wash. As the liquefied cortex is stuck at the equator, and a little more duration of irrigation under the rexus margin towards the equator may push this liquefied portion out. So tips and tricks holds due importance to understand each of these cases and improve the surgical skills in the learning days. So this case has never been reported till date in the literature to the best of my knowledge, and it will be useful to all present here in the best interest of improving skills, as manual SICS is also a wonderful surgery. So learning is forever and not the mistakes. Thank you very much.